Good afternoon, everyone. Thank you all for being here. See a lot of friends and colleagues from the field that are joining us. Great to see you, and for those that I haven't met or interacted with on Twitter, it's a pleasure to meet you, and I hope you get a lot out of today's presentation. If at any time, if you can't hear me clearly, or if you have a question, as Jessica said before, please put it in the chat box. We'll try to get through them throughout the presentation or at some predefined times. I will be talking slightly quickly today, not just because I'm from the Northeast, but because we have a lot to cover. We may not get through everything, but you'll certainly have access to a copy of the slides if we don't get to the end of the presentation, where we'll be talking about language research as it applies to recovery. But with that, we'll go ahead and get started. So briefly on the agenda, we're going to go through, I'll give you a bit of more background about myself. Jess did a good job. We're going to talk about what recovery is in different applications, different definitions, et cetera. The core reason why you're here today, we'll go into talking about what exactly recovery science is, moving into recovery-informed theory, which makes up the bedrock of this kind of emerging field of recovery science, and then going into more practical application and published research over the last 2 or 3 years, looking at recovery-oriented systems of care or recovery-ready communities, recovery community organizations, both models of those, standards of practice and service delivery, but also hybrid RCO case studies, or hybrid recovery community organizations. Then we'll talk about a newer model of care that was just published, theoretically, the Recovery Community Center Office-Based Opioid Treatment Program. And then we'll end with, if we have time, some of the research that's emerging and existing on language bias, stigma, and discrimination. So a jam-packed agenda. So a little bit about me. So Jess said I am a macro social worker, so I've never been a clinician, and I'm also a recovery scientist, and we'll go over what that means here in a bit. I am a PhD student at the University of the Sciences. I'm a researcher there at USciences at the Substance Use Disorders Institute, led by Dr. Andrew Peterson. I'm also a research assistant at the Treatment Research Center at the University of Pennsylvania Perelman School of Medicine. The managing and founding editor of the Journal of Recovery Science, our namesake for what we're talking about today, which is at recoverysciencejournal.org. It's an open access journal if anybody hasn't heard of it and is interested in some of the peer-reviewed publications that have come out. I'm also the director of a recovery community organization and recovery center in Philadelphia called Unity Recovery, which is a nonprofit. And then I'm also a person in long-term recovery. And perhaps most importantly, I'm also a new dad to my lovely 4-month-old daughter, Penelope, who you'll see there to the right. And I did get permission from her mother to use our picture. So switching more into some of the roles in terms of research focus, and a lot of what makes up what we're going to talk about today. So I'm focused on recovery support institutions, ROSCs, linguistics, stigma and discrimination as it applies to behavioral health and recovery, pharmacotherapies for substance use disorders, which is otherwise known as medication-assisted treatment, machine learning and predictive analytics, especially applied to public health outcomes and recovery outcomes over long-term periods, harm reduction services, collegiate recovery programs, recovery high schools, health communication and health literacy, again, as applied to substance use and mental health, and digital recovery support and social networking. And we'll come back to this image on the right in a second. We're going to go through each one of those. So let's get right into it, right? And some of this will start with a precursor to look at and set the stage for everything we're talking about today. So what is recovery? And I was really heartened to hear or see the poll results that most people thought it was an individual process, so that's how they would define it. Which I think is a really good way to define it in 2019 as we've learned more and more. But as we look kind of over the last 2 decades and perhaps even longer, both the substance use disorder and mental health disorder field, and collectively I may refer to them as behavioral health throughout the rest of this presentation, but there's been several attempts at defining the word and the concept of recovery. Many of you probably know and have seen some of these definitions from SAMHSA, ASAM, Hazelden Betty Ford Consensus Panel, or the Foundation, and there's been several others, the Scottish Rite, the UK government, John Kelly and Hopner had published a paper on this. There's been several definitions over the last 20 years, essentially the point of this, and you'll see some of those over from an image from the Recovery Research Institute, give us permission to use this image, but really each of these has its own merits and weaknesses, but there's yet to be a true consensus among both the scientific and professional communities or even the lay public. The idea is that we don't have a consensus definition where everybody agrees that this is how we can conceptualize and define recovery through various iterations or for various purposes. So being true academics, of course, we had to define it for ourselves, but we did take a slightly different approach to this. So when I say we, this is the Recovery Science Research Collaborative, which is about, at this stage, 40 different researchers and practitioners, largely early on in their career, but certainly a diverse mix of experience and backgrounds and educational experience. But we get together once a year to engage and kind of lay the trajectory of our future research for the preceding year. But one of the first things we did when it was founded in 2017 was say that we need to come up with what definition of recovery we're going to use. And we've started by reviewing, the 14 that had been created. None of them hit exactly where we needed to be, though SAMHSA's was certainly closest. But for us, since we were laying the groundwork for both recovery science as a field and a topic of inquiry, so we needed more of an operationalized or a way to measure systematically, we did need a more robust definition for our purposes. So this is the definition that we published in the Journal of Addiction Research and Theory, which is a peer-reviewed journal in 2018. And we've defined recovery as an individualized, intentional, dynamic, and relational process involving sustained efforts to improve wellness. A lot of similarities to the SAMHSA definition, certainly shares similarities with some of the others, but again, closest to SAMHSA's. Some of the characteristics or hallmarks here is that you'll notice it does include both mental health and substance use or behavioral health kind of writ large. And it also helps preclude discrimination resulting from individuals using different pathways and programs of recovery, whether that's abstinence-based or harm reduction in moderation, whether it is medication, whether it is doing yoga and other physical activities, whether it is going to church, whatever that might look like, it includes the funnel or the umbrella is large enough in this instance under this definition to include everyone. And even without true consensus, right, recovery should be used for research, policy, and public health purposes. These major tenets can come out of these definitions is that recovery is an individualized and self-directed process, though certain characteristics related to outcomes can likely be applied to general populations. There is consistency when you're talking about millions of people, but inherently it is an individualized and self-directed process. It also doesn't follow a linear progression, nor is it time limited. So it is dynamic over time, dynamic meaning that it can change. As a person in recovery myself, what my recovery looks like today is much different than it looked like 6 years ago. And we find this to be true from a public health or population health perspective. We see this to be more true more often than not. And also that recovery begins through various access points and can progress through various pathways and programs, back to that dynamically changing over time. So that everybody's pathway or entryway initiation points can be wildly different, just as their long-term maintenance or sustaining of that recovery process can be very different and individualized. And we also know, and it sets the stage that from an interpersonal relationship, that no matter where and how recovery is initiated or sustained, it does most often flourish and maintain itself within a community setting, whether that's identity, geographic, social, or other versions of community at the individual level. That's where people live, work, and thrive, especially after medical stabilization, intervention, treatment, et cetera. So what does recovery look like across the U.S.? And many of you are probably familiar with this, but perhaps not. For a really long time, we used to say the field, especially in the advocacy space, that was 23 million Americans living in long-term recovery. That wasn't necessarily the most rigorous of studies that actually came up with that number. It was more of a consulting firm that had been contracted and partnered with New York Oasis, did a lot of random sampling via phone, but it certainly was not what we would consider like a rigorous national or representative sample. But luckily, the Recovery Research Institute, led by Dr. John Kelly and his colleagues, completed the National Recovery Study in 2017, and it found similar numbers. So it estimates that 9.1% of the U.S. population that's 18 years and over, non-institutionalized, has resolved an AOD problem, or alcohol and other drug problems. So this does not include mental health, just for the sake of conversation if you're following along. So what does that actually translate to? And there's some important things to take away from this, but it doesn't actually say 9.1% of the population is in recovery. It has resolved an AOD problem. And about half of that 9.1% actually self-identifies as a person in recovery. It's about 10 to 11 million. I think it's 10.28 million exactly. And the others would say that they've resolved an AOD problem. So if we get down to, it's not just semantics, it's important to note that there is about 22 million people that have resolved an AOD problem, but only about half of those would consider themselves and identify as a person in recovery. So 11 million, give or take. Of all of those, about a little over half, 53.9%, did report resolution of that AOD problem via some type of assisted pathway or lifetime use of a formal support mechanism, whether that's treatment, medication, counseling, recovery residences, or other types of recovery support institutions. They did use some type of formal support mechanism, including mutual aid, which also means that slightly less than half did not use an assisted pathway, or they naturally recovered, is what we'd consider it in the field, and it's been published on quite a few times over the last 50 years, is that it's not that they naturally or spontaneously remit, if you will. It's just that they don't use formal support. So they may already have high intrinsic human recovery capital or human social capital. They may have high interpersonal supports, but they may mature out of their problematic substance use or substance use disorder. But again, about 46% or so don't actually ever engage with some type of formal mechanism. And again, these numbers line up with what a few other regional studies that have been looking at recovery prevalence as well as national, of about 9 to 10%, which is within a margin of standard error of all the studies today. So we're pretty confident in that number. But at any given time, not only is there 23 million Americans that have a past year substance use disorder, if you look at the NISDA results from SAMHSA, but about 22 have resolved an AOD, and about 11 of those identify as a person in recovery. So importantly, and what we can take away from this range of studies in the National Recovery Study, and again, this begins to set the stage of what recovery looks like outside of just a theoretical definition that any group has published, including ours. But what did they find amongst these thousands of people in the sample and extrapolated to the millions of Americans across the U.S. over the age of 18, is that not all who resolve substance use disorders or in recovery are actually completely abstinent within their life today. So within their recovery, or within whatever they might identify as in terms of problem resolution, they're not actually completely abstinent, which I think it may be a surprise to some or may not be. But among those identifying as in recovery, so if we were to ask people, are you in recovery, here's what they would say, or what they reported. About 59% were actually completely abstinent, so a majority, but certainly not all. 17.3% were only abstinent from their most problematic substance, so somebody that might have intravenously used opioids or heroin, no longer uses opioids, but may use medical marijuana or cannabis or still drink, but they're abstinent from that identified most problematic substance. And an interesting 23.6% weren't abstinent at all. And again, this is amongst those that actually said, I'm a person in recovery, not just those that have resolved an AOD issue, but among those that don't identify as in recovery, we see very similar numbers. So there is some variance. 45% were completely abstinent, 25% were only abstinent from the most problematic substance, and then 29.6% were not abstinent at all. And I think those slight increases or decreases amongst those categories we would expect. But again, it begins to paint a picture that, and again, most of you didn't define recovery as abstinence, but there is certainly still a large portion of the addiction, behavioral health, policy, practitioner fields, the recovery community itself that would say abstinence is a predicated requirement for recovery. And it just doesn't bear out in again, population health studies or epidemiological studies that happens to be the case. So when we say things like that, we begin to exclude millions of people and their lived experience and identities. It's important that we don't, and we continue this trend to identify and characterize recovery as it exists in real people's lives on a day-to-day basis. So parsing this all together and putting it to some big takeaways for you as you begin to think about this, we see that recovery is a nuanced and individualized process, right? It lines up with that definition and how most of you defined it today. And it's likely to occur across a variety of pathways and initiation, so both formal and informal or informal points, or natural recovery versus assisted recovery, again, lining up with definitional parameters. We also find that, again, as I said before, that recovery defined by abstinence only, whether you're a practitioner, a lay public, policymaker, key decision maker in your community, or a professional, that doing so is an incomplete picture and discounts the lived experience of all of those other millions of Americans, but it also sets the stage for really bad interventions, evidence-based practices, because we're not serving people that are best served by the same interventions. They don't have the same trajectories. Our long-term supports may not reflect the support that people actually need or want to utilize, because we're serving only a segment of the population that actually exists that need these interventions and long-term recovery supports. And again, we find that most Americans naturally recover without the use of those supports. And it's a message that we at least need to know that it does happen. So not only is recovery possible, but it's possible by many different ways. And that's my favorite meme in the world for anybody that likes memes of the squirrel. So what is recovery science, right? So what are we here to talk about today before we get into the research? So recovery science begins to place everything that we do as an organizing paradigm, whether that's research, practice, policy, and it used to only be, we need to think about it as a system of care. It was an approach or a paradigm. But for us in recovery science, the science part of this, it's how we formalize and organize our research agenda. What empirical questions are we going to ask, and how do we want to answer them? What are the methods that we're going to use? And this really came together as we started this 3 years ago to create and kind of prop up recovery science as a standalone field rather than a subset to addiction science. Addiction as both this primary and secondary pathology is generally well studied. We still have a lot to learn for sure. But Tom McClellan, Bill White, and so many other names that I'm sure I might offend somebody from not saying them, but we've had addiction science for quite some time, and we have some pretty good, solid understanding of outcomes, interventions, evidence-based, et cetera. But within that field of inquiry, recovery was often relegated to this binary outcome of percent days abstinent or positive and negative urinalysis, et cetera. It was this kind of tertiary outcome rather than this full, robust concept in and of itself, which really didn't make much sense, especially for those of us in recovery that had lived this and were doing qualitative work. This phenomenon, this process is so robust and such difference and variance amongst people. It really is a topic of inquiry or a field of science, scientific exploration in and of itself. And that's where this kind of birthed from. So it separates itself out from addiction science as the exploration of recovery as that process and phenomenon, more than just an outcome to a experimentally or randomized control trial, et cetera. But as a topic of scientific inquiry, it's still in its relative infancy stages, and the opportunities are exciting. We're going to talk about some of the innovations and the publications that have come out over the last couple of years, but really we're talking about a field that is named and where there's a growing trend of researchers, though there certainly has been recovery scientists, as I would call them, for many decades, with the growing momentum of people actually collectively setting research agendas and making this the primary point of inquiry. It's, again, certainly in its infancy stages across the U.S. and even internationally in the U.K. and Australia and other parts of Europe. There's a growing contingent of recovery scientists as well. So what is the justification, again, for having this, to go just a little bit deeper? And really what it came down to as we explored this is that how people get well, so how they recover, differs from how they became pathological or they developed their substance use disorder. And the absence of specific symptoms, including abstinence, is not in and of itself an indicator of health or growth. So that it begins to move into recovery as quality of life improvements over predetermined periods of time, that the absence of sickness in and of itself is not an indicator of that growth. So we have to begin to explore what more and how more robust that it gets. And we know that the engine of recovery is growth across multiple substance use disorder related, which would be the addiction science, and non-substance use disorder related life spheres, things like employment, other social determinants of health and recovery. And also that recovery is inherently interdisciplinary. An attempt to reduce it to one field detract from the scientific understanding of recovery. And a case in point here is we look at the Recovery Science Research Collaborative. There's everything from public health researchers to social work researchers to more traditional mental health and addiction treatment researchers to policy analysis to program practitioners, et cetera. And it's that interdisciplinary nature at its core of this growing field of recovery science that is one of its key tenets of strength. And again, as I already said, and this doesn't just come from what we see bearing out in the data that we've already talked about, but again, recovery is more than just an outcome. It cannot just be an endpoint on a study. And this comes from, again, both the data, but more importantly, from those that have actually recovered themselves. And we see this time and time again in mixed methods and phenomenological and other qualitative research that has come from the UK and the United States, that recovery, again, is this very nuanced field and process that we have to understand better, and it cannot just be that outcome. So as we put together this work, and we talked some about defining recovery, and you'll see, again, I think it lines up nicely with what we look at a population level from the National Recovery Study. But we began to set a framework of how we've orientated all the research that's being done within the recovery science domain. And the first stage to do that, and really kind of any emerging or new field, starts with what we call grand or meta theories, and it's kind of a theory of everything. What sets the paradigm or empirical framework, the philosophy of how a field engages in itself. And for recovery science, this comes from recovery-informed theory, at least from how we've positioned ourselves. And recovery-informed theory was published as a grand and meta theory in 2018, and it posits that successful long-term recovery is both self-evident and a fundamentally emancipatory process. And what does that actually mean, right? So first and foremost, it places the subjective experience of recovery trajectories, meaning the experiences of the individual kind of carte blanche for themselves as the chief laboratory of recovery science. This is not done in clinical settings. This is done in real-world settings, not laboratories. We examine and study recovery where it exists naturally or in situ. It also relieves this intellectual obligation to prove recovery. We can just begin to inquire and examine recovery from an understanding that it is possible. We do not have to prove efficacy or whether or not recovery is even real, which many other fields might say that we need to. But the reality is we have millions of people that live and identify in this way, and we can just begin to move forward as this is true. This is a truism, and what comes next. And it also allows recovery to be what it is, a phenomenon that is not well understood, but we know that exists. And hopefully that won't be the case forever. And what I would like to think is one of the most important points for the field, because it's a bedrock of recovery science. Again, the approach that we do this work is that it's the individuals in recovery are at the center of the science. So it's not just that they're the studied subjects, they're actually co-creators and researchers, and many times within this framework in recovery science, as we talk about some of the research later, is that it's engaging in a community-based participatory research process. It's a core method of recovery science. So rather than this power differentials and dynamics, if you're familiar with peer recovery support services, this may sound familiar, but it takes away and reorganizes how research and empiricism and epistemology is actually known. And this is critical when we start talking about recovery in disenfranchised communities, that we begin to uplift and re-empower or restore power to people in recovery out in the communities and not just study them like lab rats. And it's one of the reasons the Journal of Recovery Science was started too, so that the research was about them. We're not hit with paywalls to go see the research that was being published on their communities and their experiences. So we, again, live this both in the research, but also the translation to the real world. And finally, it situates emancipatory states of human freedom as the directionality of research. So it's inherently strengths-based. And I know as a social worker that may seem, there's many social workers on the RSRC, but studying and directing the research as a strength of that human freedom or human healing and wellness and recovery, that's the directionality of the research rather than pathology or sickness. As we look at recovery science too, and again, providing an overview of how this work moves forward, here's the way that we have situated, again, recovery measurement methods. So rather, again, if you remember back from a few slides ago, it's not just a binary outcome of % days abstinent or whether or not somebody has a positive or negative urinalysis, but we're looking at longitudinal data collection, so multi-time point data collection in years, not months, and a variety of interpersonal and interpersonal outcome measures, which include many of which you might be familiar with and some not. So the assessment of recovery capital or recovery capital as a concept, we use most often the brief assessment of recovery capital or the BARC-10, validated by Dr. Corey Saint and others from RI. Measures of human flourishing and self-esteem and self-efficacy, personal growth, stigma, both internalized and perceived, hope, pro-social battery, which is a measure of altruism and empathy and service work. And you'll see for those that are non-12-step recovery, so those different paths, and then also service to others, which is similar to the pro-social battery in terms of altruism and empathy for those that are in 12-step recovery paths, and looking at similar measures that have been validated for different populations. And again, to harken back, that all of this is done within a community-based participatory research framework that we're engaging as a prerequisite in recovery science, that this research includes the people that it is about, both in designing studies, collecting data, and doing the work, and then also publishing those results on the back end. And where possible, whether this is in pilot studies or phases, phase 1, phase 2, phase 3, and then building upon each other, or in single mixed methods research, is that we're using both quantitative and qualitative methods in engaging with this in this research. Again, because formulating hypothesis, and this is generally it happens in every field, but it's critical for us that we're generating knowledge by learning from stories and from phenomenological perspective of those that are in recovery and have these experiences, people who use drugs, et cetera. So I'm going to stop there just to see if there's any questions before we get into, because we're about to transition into talking more about what's actually been published under this banner of recovery science over the last couple of years.
Great. There's a couple questions. And the first has to do with the RCSC definition of recovery. And it says, why does the RSRC definition make no reference to mental health or substance use disorders?
So it's by intention. So if you actually read the paper, which you can, it's that recovery from behavioral health disorders is defined as this. So it's definitionally recovery from behavioral health disorders, and inclusive of both mental health and substance use.
Gotcha. Okay. And then we have both a question and a comment, but they relate to the same issue. So I was going to combine them, and they have to do with the people who identify as being in recovery or do not identify as being in recovery, but are not at all abstinent. And so the first question is, of the people who are not at all abstinent, I assume they have moderated their use. Do we know anything about what that moderation looks like? And then the second comment is, just because someone in a survey says they're in recovery, but they have not stopped using, does not mean from most of our standpoints that they are in recovery and meet the definition, whatever it may be, of recovery. I disagree with this presenter. So it looks like people are kind of interested in exploring a little bit more about those folks who are not abstinent.
Sure. So I'll start with the comment, and I think this gets back to the point. We have to be very careful. And actually, the poll at the beginning just for this webinar, since we had said it wouldn't agree from the standpoint of most of us, it's actually not true. So most people on the poll did not define recovery as abstinent. So I would disagree with the comments, and I think from our understanding and what is best known, that people do not have to see substance use to be in recovery. It certainly can. It can be a primary outcome for some, especially with the self-directed goal. But we see natural recovery and moderation and non-abstinence in people living fulfilling lives and improving their quality of life, gainfully employed, finding housing, repairing relationships, resolving criminal justice issues, and all with not being completely abstinent. So, I mean, again, I respect the comments, but again, that's just not what we begin to see out in the world. I think that's a kind of old understanding rooted in paradigms for different reasons, whether it's drug policy in this country or other, but we don't have to, I won't get off that soapbox. And to the first question, which I think is a great question, and it details and highlights how much we don't know. So the National Recovery Study was done in 2017. There's been a ton of publications that have come out on it, but you've got to realize that it's one of the first studies that even identify that there's people who say and have identified as a person in recovery that aren't completely abstinent or partially abstinent. It's one of our first looks at it. So it was not originally designed to analyze and characterize those populations at great detail. It was a huge battery of a representative sample, and this was just one data point in it. So I think we have a huge need to continue to further examine and study, create predictive models, identify what characteristics are likely to put somebody within an abstinence-based recovery kind of characteristic versus a non-abstinent or partially abstinent. So we have a lot to know, and we don't know a ton except that these people do kind of inherently exist. And I'm of the mindset to believe people self-report. I don't dare to define recovery for anyone. I'd rather listen to their definition see what that means. So the short and long of that is no, we don't know a whole lot more about them. And hopefully, as NIH, NIAAA, NIDA, et cetera, begin to fund more recovery-related research, or philanthropists do, there will be a lot more studies over the coming decade that begin to characterize and illuminate our populations that we're talking about in much more robust ways. And I think for the sake of time, we'll pause there, and then we can get to any other questions at the end.
Sounds good. All
right, so with 23 minutes left, I'm gonna speed it up some. So many of you are probably familiar with recovery-oriented systems of care. This idea that within communities that all different types of supports can be interlinked and interrelated to provide long-term continuums of care across a spectrum of social service needs, medical needs, interpersonal needs, et cetera, was really popularized by Bill White and many others. The city of Philadelphia, where I live, went under a ROSC transformation 20 years ago. So certainly is not a newer concept, though it is not in place at all of our systems and all of the localities across the U.S. or the world yet. And many of you might have seen this from SAMHSA in 2010. Again, we've seen a lot of movement towards long-term systems of care versus acute stabilization systems of care through the advent and implementation of ROSC around the country. And again, as a foundational framework, the ROSC lines up nice with recovery science as it centers the recovery experience at the individual, the family, and the community as the focal point, and then has a process of continual self-improvement and evaluation to connect resources to make sure warm handoffs are happening, et cetera. And it can also be used, and this is where we get into innovation, because some of the original ROSC frameworks stopped at how do we actually evaluate if ROSC are making a difference or if a ROSC has any type of efficacy in improving outcomes. So it can be used as a starting point for community assessment and recovery support efficacy evaluation as we look towards some of the innovation and recent research. And that comes to some of the theoretical underpinnings of recovery-ready communities, which takes together all of the different types of elements, including more readily or more recently created one like harm reduction services, and puts them within a framework. So if we look at ecosystems, for those of you that are familiar with Rothenbrenner's work, we begin to look at these contexts, our ecological contexts at the policy or national level, the institutional level, the community level, and the individual and interpersonal level, and how all of these different things are interconnected and have an impact both on the level preceding them, but also at the individual and interpersonal level, everything impacts that. And we begin to look at what are the different types of supports that make up or could be in a community that could support and impact long-term recovery with both local, state, federal policy at the very top, at the macro level ecosystem, and the individual at the very bottom. And in the middle, we see things like recovery-informed institutional services, prevention organizations, harm reduction organizations, recovery community centers, recovery courts or drug courts, CRPs and recovery high schools, advocacy organizations, peer recovery services, medical services, and treatment services. And again, from the original ROSC, harm reduction wasn't included at all, and CRPs and RHS, which were newer from its original creation, were also not in there. And this is coming off a paper published by our group in 2018. And this is how we get to this framework of how do we evaluate and use recovery-related research to begin to create practical and translatable tools in our communities. For those that aren't familiar with recovery capital, it's essentially a variant of human social capital or human capital that are the resources either in the internal or external level that somebody can bring to bear to support their recovery, and whatever that may look like, really by marked improvements in quality of life. And then community recovery capital could be construed as the same thing, and this is a newer concept of what are the intrinsically available and and the external resources that a community can bring to bear to support the recovery of its citizens. And again, whether that's a geospatial community or an identity community, can be any type of community. And this can apply to recovery readiness. The theory and underlying this is that a community that has higher community recovery capital, similar to a person, can actually support and initiate and help individuals sustain long-term recovery at higher rates. In the paper that came out in 2018, we actually began to put this framework together of how a community recovery capital can be quantified and then used by policymakers, funders, practitioners, and local community stakeholders to increase its community recovery capital, therefore giving greater chance of long-term success to the people initiating and living in recovery within their community. a quick case study. So we actually applied this in Eugene, Oregon. Again, this just some disclaimers, an abstract representation of a single community, and there's a likelihood that not every resource was mapped. But you'll see that we took a geospatial community, so 63 square miles around Eugene, Oregon, and mapped the different recovery support institutions and other services that we had previously talked about and where they exist within that geolocation. And then begin to look at how these things theoretically should be interconnected within a ROSC system, that they're cross-referring or bilateral connections, they're meeting regularly, they're creating long-term continuums of care, no matter what supports a person might need. This is what a fully functioning system in a ROSC should look like. But part of that, and ROSC requires to see, are these things actually referring to each other? Are they aware? Are the bilateral connections working? Are they creating a true continuum of care? Or is it just disparate individual resources that have no idea the others exist? So we chose 5 at random that were found in the mapping and called to inquire about information about another random resource in the list for potential referral. And out of the 5 inquiries, none could provide information about the requested resources or how to access it. It doesn't necessarily mean that that's an outlier, but again, we begin to look at not only can we find the resources and map them, but that in and of itself is not enough to say that an increase in community recovery capital. To truly be a recovery-oriented system of care, these things should be talking and have bilateral connections to each other. And 0 out of 5 did in Eugene. And I think we would, if we were to do this around the country, and we've got a pilot in 3 other cities where we're doing some of this work, to get an assessment of community recovery capital looking at their system of care, this is unfortunately much more frequent. So again, we begin to see applications and extensions of ROSCs using recovery science frameworks and qualitative work and how these things should work in a fully functioning, robust system to evaluate these things. So real-time translatable resources based off the research. And we begin to highlight the importance of bilateral connections. So if resources are present, but they don't know about others or don't warm hand off or don't cross-refer, it doesn't actually improve, or it's not the implementation to efficacy of the model of a ROSC is not there. And it also begins to highlight, just from a mapping perspective, if we're looking for certain resources and they don't exist, we can identify resource and service gaps and then advocate either for change at the policy level for more funding to prop them up, or to create resources that should be present that we know impact community recovery capital and therefore individual recovery capital that may not just be present. So a really kind of recovery-centric form of community mapping and needs assessment. And the last point in this, which we haven't talked about, and it's much more in the paper, but I think it's important to know for anybody that's interested in this, is that, especially from Brofenbrenner's ecological systems theory, that resources being present and even having bilateral connections and everyone is talking, there's a robust continuum of care without any service gaps, that it also matters the individual has to perceive those referrals and the services they utilize as beneficial, that there's a perception of utility, and without that perception of utility, the efficacy of that service is actually diminished. So it also matters that how people perceive the resources they can access or do access is likely to impact their chance of success. So from a algorithmic score of community recovery capital does have to weight that score if we begin to include the recovering community or people initiating recovery of what their perception is. So again, they're centered within this work because how a community can support its citizens within a recovery community does matter about the lived experiences of that individual. I'm going to skip over that. We'll go into RCOs and recovery community organizations. For those that aren't familiar, recovery community organizations, which there's about 120 at last count around the country, and they're really a byproduct of mutual aid recovery support services. Things like Wellbriety or American Indian Talking Circles, the Oxford group, which led and gave rise to 12-step mutual aid groups or programs, 12-step clubhouses, which still exist around the country, and the confluence of the modern-day recovery advocacy movement in the early 2000s, which hopefully many of you were a part of, gave way to these community-based supports that embrace holistic approaches to recovery, this concept of multiple pathways to recovery, that there's no one right or wrong way to recover, which began to line up, again, with what we know now exists kind of naturally across the country. And these services, for the first time, were really agnostic to the pathway or the entry point to recovery, and they were designed to be a place of peer-based and community recovery supports across a range of pathways and modalities. It was almost like non-denominational places of worship, if you will, that these were recovery clubhouses versus 12-step clubhouses, that everybody was welcomed and included and provided support regardless of what their recovery program looked like. There were supports and all types of different mutual aids and peer-based services, et cetera. And we see this model continuing till today. In the peer movement, because it's such a critical component of this, it's important to note that it predates the substance use disorder recovery space and has much to owe to the peer movements of both the HIV and AIDS and mental health fields, which those of you in the mental health field likely know that, but I think a lot of the peers in substance use disorder may not know some of their history, that it didn't actually originate with us. Peer advocacy movements and anti-pharmaceutical movements, especially in the HIV and AIDS and LGBTQ+ communities, were precursors as well to what is happening today. And so this idea of the combination of the peer movement plus mutual aid communities on the substance use side plus substance use disorder advocacy, at least within substance use spaces, really led to this creation of these 120+ recovery community organizations and centers around the country. First ones, again, established circa 2000 around the Summit in Minnesota. And these organizations are community-based, peer-created, and peer-led. They're not clinical, and nor are they created by government or clinical entities, at least not authentic RCOs, but there certainly is growing trends in some places of the country where these things are being propped up and created and run by both clinical and governmental entities. As we look across, and this begins to get into some more of the innovation within the RCO space, because RCOs are at this point almost 2 decades old. So we have traditional RCOs, which would have been created by the community or are created by the community and focus on providing a range of in-house peer-based recovery supports, otherwise known as recovery coaching, and resource brokering, not to be confused with patient brokering or warm handoffs. We have these hybrid RCOs, which have been popping up. There's now 3 in the country that we're aware of in the last 3 years. They're also created by the community and peer-based, but it's a combination of harm reduction peer services plus these traditional RCO services, so like the Rebel Recovery or Missouri Opioid Recovery Network, which has peer-based syringe service programs, as well as traditional peer-based recovery support services would be a hybrid RCO. And then we have quasi-RCOs, which again are created by institutions or treatment programs, and may or may not be community-based, may or may not actually employ peers used to their full capacity or actual suggested scope of work from the evidence base. And there's a paper that was published in 2018 around hybrid RCOs and the different models, the marriage of syringe exchange programs, recovery community organizations leading to RCOs, and the first published study on those. So again, a very new innovation cropping out of peer-based recovery and harm reduction services. Another hybrid RCO example, and this was a paper just published in Addictive Behaviors, and it's about half of the authors are peer-based workers actually at the hybrid RCO in Florida called Rebel Recovery. It's the second hybrid RCO that's documented in the peer-reviewed research. And essentially, though you can certainly read the paper, there's a tremendous amount of findings in it, is it provided the first empirical basis for these hybrid RCOs to have increased engagement and service opportunity for some of the most underserved populations in our community, our meaning the kind of PWD or people who use drugs, the recovery community, et cetera. So people experiencing high rates of homelessness, intravenous drug users, and other disenfranchised communities were some of the most often served with lower rates of attrition, provided Narcan, provided recovery supports, provided sterile syringes, et cetera, some of those highest at risk for overdose, et cetera. So we begin to see a linkage between hybrid RCOs and their potential efficacy as a new standard and model of care within the recovery community. Again, for the sake of time, we'll gloss over some of this. But again, to hit this, recovery support services at RCOs are non-clinical. We begin to see this more and more for those that aren't familiar with them. Their services are delivered by certified peers who should be paid, but are often volunteers still, which speaks to the underfunded nature of recovery support services in the country, but should be moving to a paid model, hopefully more and more. And for those that aren't familiar with peer services, there's some bullets on the screen, but I think that some of the biggest, or the 2 biggest points to take away is that peer services are predicated on a power dynamic with the person receiving those services that is roughly or is equivalent to 50-50 as possible. It's one of the beauty and what we believe is one of the mechanisms of why peer services have shown to be effective in mental health and substance use fields. And one of the primary mechanisms is recovery planning or recovery coaching. And the mechanisms of delivering those support either in vivo or in person and also more recently with some emerging research digitally through smartphone apps, websites, forums, video chats, etc. I'm going to skip over peer supervision. That may be a great topic for those of you that are in recovery supportive environments or institutions. Peer supervision is an emerging topic that there's still best practices and trainings being delivered around. I think it's important to talk about, but perhaps a different time. So to wrap this all up and what we know today, and as we begin to, in 2019 about RCOs, of characteristics, since they're still somewhat of a novel intervention, they should be community-based and peer-driven, paid staff, not volunteers, an individualized recovery and wellness emphasis versus no predilection on particularly adherence to treatment plans or medication or anything like that. There certainly can be a focus on it, but the overall goal is a strength-based perspective focused on recovery and wellness. They partner with all organizational types rather than being beholden to any, only to the community itself that it serves. We found that they're very flexible and responsive to community voice. And then we see this, again, more recently, especially with peer warm handoff emergency department programs in the age of the opioid and overdose crisis, these mobile responsive services too. Again, it's community-based responses deriving out of the recovery community in response to national trends. And one of the last things we'll talk about, we're not going to get to the language today, just FYI being at 2:53, but one of the more recent innovations, again, from a theoretical perspective, coming out of the recovery science field is this new model of care called Recovery Community Center Office-Based Opioid Treatment Programs. Again, published also in Addictive Behaviors last month and comes out in print in November. And what the RCC OBOT is it's combining several recent recovery-informed and OUD treatment models, primarily low-threshold programs, emergency room, warm handoff programs, pharmacotherapies, and hybrid RCOs to create patient pathways and individuals initiating recovery pathways to respond to both overdose and non-overdose events. And one of the beauties of this model is that it maintains the peer relationship dynamic that is important, that 50-50 power dynamic relationship I just mentioned, and integrates recovery supports with intention in the community. So rather than co-opting peers and placing them in medical settings or in treatment centers, which is certainly a growing trend, especially with the way Medicare and Medicaid billing is working across the country. But a model like this allows the authenticity of RCOs and recovery community centers to facilitate partnerships without being co-opted by either themselves or their staff with other organizations, which is a growing discontent within the larger recovery support institutions that are community-based that we're beginning to find and some of the qualitative and grounded theory research work that we're doing with them. Here you can see, and again, probably very small on your screen, but you have to read the whole paper, which I'm happy to send the PDF if anybody can't get behind the paywall. But you see, again, patient pathways based on an overdose event to getting somebody inducted into pharmacotherapy and immediately connected to a peer in the community at a local RCC, and then provided long-term recovery support services in addition to medication. And then you see patient pathways for a non-overdose event, which we also know is critical and needs as much intervention pre-overdose events for those that are using opioids of various types. So I'm going to stop there because we're not going to have time to go through all of the language, stigma, and discrimination and see if we have any questions. And while that's on, I am going to leave it on the language infographics just so people can take it in while we finish with any last questions that may have come up.
All right. So let's see. We did have some additional comments primarily about the issue of abstinence and recovery. And so I don't know that we have time to share all of them, but I did want to share one of them because I think it comes from the perspective of a treatment provider. And so she's kind of concerned about if abstinence is not defined as part of recovery, how do you work with patients and try to explain to them what recovery is? Yeah.
So I think it's important because, I think just because, that's not the takeaway, because that's not actually what was said. Abstinence is a part of recovery for some, and that what we don't know is is that predicated or predicted by severity of the substance use disorder? Is it a self-directed choice? what is said is that abstinence is not a part of recovery for everyone, which is a very clear difference between recovery or abstinence isn't part of recovery, because it certainly is. And I can say that as a person in recovery, complete abstinence is part of my recovery, both clinically necessary and my choice. But the statement is not that abstinence is not part of recovery. It's that it's not always part of recovery.
Mm-hmm. Great. I think that really does address that question. How could you speak to clients about recovery?
I think it's important just because there's a lot of treatments and clinical providers on here, is that clinical orientation in your individual program, especially if you're an abstinence-based program, this isn't meant to redirect. This is, if we look holistically, again, at the state of the field, the continuum of care, we see growing treatment providers and programs that are not fully abstinent-based, so especially low-threshold pharmacotherapy programs where people are inducted on various pharmacotherapies, are not administratively discharged for using other substances. We see markers of success in some treatment programs that are harm reduction focused, like harm reduction psychotherapy, where moderation is a goal. But that certainly doesn't mean that if your treatment program is abstinence-based, that it should not focus on that form of recovery, and people being referred and enrolled and engaged in your treatment program that it's clinically necessary for. I think it's really, we're talking about a larger picture that in terms of services that we need to be able to serve the millions of Americans, not just the subsets that may require a one abstinence, because there's a lot more that look differently and are characterized and would be best served by interventions that may be different. So we need everything. This certainly is not a shot at abstinence, and I hope that's not the takeaway for anybody on the webinar.
Great. We had a couple questions about recovery capital as it applies to family members. So someone said, does recovery capital also apply to family members connected to the person with addiction? Oftentimes family members are left in the dark to search for answers as we go along. And Al-Anon and Nar-Anon can be nice, but they don't cut it. And someone else similarly said that in their area they don't have any programs for family members. CRAFT is great, but inaccessible. How do you provide recovery capital to families?
Yeah. So I think there's a couple of things to go that we see. There's growing movement to not only include the family in the recovery process, and I think it is again client or individual specific, because we do know some people, family may be a huge source of trauma. They don't want to engage, whether it's in treatment or the recovery process, and we need to give people that option. But for many, family is critical. Those interpersonal relationships, both with community and family members, are critical to the recovery process. I do think for many, recovery is a family process, not just an individual one. And I think, again, it's encapsulated by the interpersonal relationships and being healed. So we do see growing movement, especially on the recovery side. We see recovery community organizations like Faces and Voices of Recovery in Greenville, South Carolina, that have an entire contingent of family-based recovery mutual aid meetings that supplement what's more traditionally known as and was mentioned, Al-Anon and Nar-Anon. They do family recovery groups. I can tell you at our CEO in Philadelphia, Unity, we have a certified family recovery specialist that her entire job is to work with families of people initiating or in recovery or who are still actively using drugs to work on their own healing and wellness. So they develop their individual recovery plan, not as a person who uses drugs problematically or as a substance use disorder, but as a family member of one. She also works with family members of loss that have lost a loved one or partner to an overdose. So we see, again, not every state, but there is movement in some states to really begin to uplift and support family members. And again, I think recovery capital can apply to so many, because again, it's a variant of human capital that even family members can benefit from what we would consider recovery support. Because again, recovery support is not always and not really about the substance use. It's about everything else. It's about social determinants of health. It's about interpersonal and intrapersonal relationships and outcomes, and what somebody needs to be successful and improve their quality of life. And realistically, everybody could benefit from that. So one of the last things I'll say to that, just because there was a mention about things not being available, and this isn't just for families. There's not a lot of RCOs. We don't have enough treatment. There's not enough recovery supports of any type or medical supports around the country, especially in rural areas. So one of the things we didn't get to talk about, which is on the slide, is digital recovery support services. So we see And these can be leveraged really nicely for rural areas as long as they have, high-speed internet access, et cetera. But there's growing communities on established social networks like Facebook, Twitter, Snapchat, Instagram, that are not only, they used to traditionally be advocacy spaces, but really helping people support their own recovery, find information, et cetera. There's certainly pitfalls to that, which we won't cover today. But I think as we look to the latter part of the 21st century, we're going to see a growing movement of people using digital recovery support services to supplement what isn't available in person, because it's cheaper. They can be lifted up very quickly. And just for a frame of reference, Dr. Brandon Bergman published a study, again, based off the National Recovery Study, and one of their findings that about 1.9 to 2.1 million people have used digital recovery support services in their lifetime. So a fairly small number compared to how many people it is, but I imagine we'll start to see increases as more technology becomes available focused on behavioral health and recovery and wellness in the next 10 years.
Absolutely. Well, there is one more question, if you don't mind. We could squeeze it in, and then if it's easier for you to answer it offline, we could have you send an email with the information. But I think it's something that people are interested in, is the hybrid RCOs. What are some of the barriers to the creation of hybrid RCOs that you have seen? I'm thinking of cultural differences between harm reductionists and recovery advocates, and how have those barriers been overcome?
So a couple of different ways to answer this, and again, a lot of this is discussed and explored within the paper. So for a more robust answer, feel free to shoot me an email, and I'm happy to send those to you or have a longer dialogue. But to the first point, some of the bigger barriers to creation, and I'll get to cultural in a minute, but it's really around policy. So harm reduction services are still illegal in many parts of this country. Both syringe service programs, fentanyl testing strips, et cetera, actually aren't legal in most states. There is growing movement politically to change those laws. So that is actually one of the bigger barriers, is that to have a hybrid RCO, you need an organization that can legally and with peer staff provide both types of services. So that not being legal is probably the biggest barrier. The second would be funding, and this applies to traditional, hybrid, and quasi-RCOs, is that a lack of funding for these types of organizations, because although they're eligible for block grant dollars, many states don't fund these types of services through their block grant. So without money, it's hard to both create and sustain these organizations. And then I think third, and we've discussed this some, could be cultural differences. And we've done a lot of intergenerational work with people in recovery to actually find out if there is how big the philosophical divide is between cultural differences between those that are embrace harm reduction as both a pathway and form of recovery or as a standalone intervention versus quote-unquote recovery advocates. And there certainly is tension. I think there's tension between traditional recovery communities and medication. There's certainly tension between the traditional recovery community and people in recovery and harm reduction. But it's not as widespread as we begin perhaps see on social media or otherwise, especially from younger populations that we've engaged with in both focus groups, semi-structured interviews, and research. And I can speak to Philly too, is that there is a nice marriage between harm reduction and recovery, because it's not two different things for many people, especially, again, those that have initiated recovery more recently. Harm reduction is part of the continuum of recovery. So the philosophical or cultural divide is not as big. There's not as big of a chasm as we might think. I think there certainly is one between more established or older generations in the recovery community and harm reduction, which is more of a human divide. I mean, we see that across all types of fields and philosophies and paradigms, certainly not just in the recovery, substance use and mental health space.
Well, terrific. I think probably we've actually run a little bit over, and there still are more questions. I'll forward the remaining questions to Robert, and we'll see if we can get any answers and resources posted on our website along with the recorded webinar. Did you have any closing parting words, Robert?
No, thanks to Iretta and Jess, all the Jesses there, and everybody, and all of you for attending. I think I would encourage everyone to check out the Journal of Recovery Science, begin to read and see a lot of this work that's coming out across the peer-reviewed research. And I think as a parting thought, if you will, especially for some of the comments, which are certainly we're no strangers to as we begin to broaden our understanding of recovery, is, and we do this in social work a lot, is to begin to examine our own internal biases and stereotypes that we might have. So if something, you certainly do not have to agree with everything. I think, you know, the nice thing about science is data is data. You don't have to agree philosophically or with the paradigm, but I think the question to ask, if anything kind of rubbed you the wrong way or maybe was shocking or you had a vitriolic reaction, is to examine why that might be and if it's in the best interest of the people that we all are trying to help. Because at the end of the day, whether it's recovery science or clinical work or peer work or anything else, is we're just trying to people live the lives that they want to live in the best way possible and the highest quality, and having a good existence. And I think if that's the core mission for all of us, there's no reason for the infighting or misunderstandings. So as we do in social work, examine what those biases might be and begin to ameliorate them in any way possible. But I appreciate the time and hope you all enjoyed it, and have a great rest of your week.
All right. Thank you so much, Robert, for such a great webinar. And I'd encourage everybody to follow Robert on Twitter, and you could probably engage with more of this dialogue there. That was a great end to a webinar, and now I just want to make it a lot more dry and less interesting by running through how to access your CEUs if you're interested. So what we're going to do is send out a couple of emails following this webinar. In these emails will be a link to the recording of the webinar as well as a PDF version of Robert's slides. Also included in the email is a link to the evaluation. We would really, really love it if you would take time to participate in the evaluation. It really should take no more than 2 minutes of your time. Also, once you complete the evaluation, you'll see a request form for a certificate of attendance or for CEUs. You can choose to skip the evaluation and proceed directly to the CEU request. You should just leave all the answers blank on your evaluation. Again, we want to thank Robert, our presenter, and all of you for your participation today. And if you have any questions, feel free to reach out to us at info@ireta.org. As you'll see from our website, we have some other exciting webinars coming up. Our next one is in September, and it's about expert and federally qualified health centers. We're really looking forward to it, and so we'd encourage you to register. And with that, a little bit late, I will close the webinar. Thank you all for attending.